All right. We're going to go ahead and get started here. Good afternoon. Good afternoon, everyone. It is fantastic to see everyone here this afternoon. So great to see so many familiar faces and some new ones as well. For those of you who I haven't yet had the chance to meet, my name is Maura Little. I am the Executive Director of Cambia Grove. At Cambia Grove, we are a healthcare innovation center focused on bridging the gap between entrepreneurs and the traditional healthcare system. Really, our true goal is to make it easier to innovate in healthcare. One of the ways that we do this is through our strategic initiatives. One of the strategic initiatives that we've taken on is around data. How can we use data as a community to advance innovation to make healthcare more person-focused and economically sustainable? As we've completed almost 100 interviews, one of the big issues is around interoperability, and one of the key players here is ONC and the federal government. So we are thrilled to bring Dr. Don Rucker, the National Coordinator for Health IT, to Seattle to discuss what ONC is up to at a very critical moment in our country's future for using data in healthcare. Now, before I hand the mic over, I want to draw your attention to one other thing. Today, we are pleased to announce that we will be hosting a Interoperability Summit, June 20th and 21st. We are bringing 2 national speakers to be dual MCs for this event, Christine Bechtel and Anish Chopra. Again, that's June 20th and 21st here at Cambia Grove. The Interoperability Summit is really going to be focused on the consumer's perspective and empowering the consumer with the use of healthcare data. So please mark your calendars, take a look at Eventbrite. It is up, so you can register now. And we can continue the conversation that we are going to have today into June. So with that, again, thank you all for joining us, and please join me in thanking Dr. Don Rucker and Lee Huntsman for joining us as well.
Wow, a mission to make innovation in health easier. That sounds like an alignment with ONC, doesn't it, Don?
I hope so.
We want to get on to that, but first, give us a little background on yourself. How did you wander into this complicated area and end up at ONC? What's your path?
Well, the simple answer, of course, is being a political appointee. You sort of have to work the D.C. circuit to get a political appointment. So, and that's the sort of usual kind of stuff. The real answer is when I got to med school, and I had sort of the usual unimaginative reason for going to med school. It seemed like something good to do. I wasn't smart enough to be an actual chemist, so I had to acknowledge that and come up with something that I could do, arguably. When I got in the first couple weeks, actually, the first time I was on the clinical wards at Penn, great hospital, it struck me, wow, this place is totally unorganized and inefficient. And so I sort of had a set point that there was a great opportunity here to do stuff just from, being sort of a beginning med student. And as I went through med school and tried to figure out, okay, well, what does that mean for me? There was a very charismatic faculty member named John Eisenberg, who's just a couple years older than I was, actually. He, I think, was a first-year faculty member when I was a med student, third year. And he was talking about decision trees, right? Sort of the Howard Rafa decisions under uncertainty for folks who've come out of the business school economic literature in this. And I thought, oh, this could be the solution, decision trees, right? Pathways, guidelines, yeah, this will be it. I'll work on that. And then I went to residency, and which is the first time you actually are responsible for taking care of patients, as opposed to being responsible for being around as a medical student, especially if you're at a county VA type of hospital. Back in the day, we were shall we say, loosely supervised. So you're literally responsible, and you realize the problem is actually not lack of decision trees, it's lack of data. So this is now 1981, and so I'm thinking, well, this looks like a computer problem, not a decision tree problem. I didn't know anything about computers. In fact, my dad had told me, don't do computers. If you need to use them, you can just program it. But I didn't know anything about it. I said, well, I'm maybe going to have to buckle down and do computer science. Mind you, at this point, I'm already through med school, late 20s and residency. So the thought of more school wasn't the most appealing thing that immediately came to mind. And I didn't really know anything about computers. There was some guy I'd never run into in my college class, some guy, Bill Gates, who I knew was doing stuff on computers, but I didn't know him, didn't know computers. But at any rate, decided that I was going to bite the bullet after residency and learn computer science pretty much from scratch. I was lucky enough to talk to people at Stanford, was just starting a medical computer science program, and I guess they thought well enough of me that modulo the detail that it's hard to get into grad school in the computer program without ever having taken an undergraduate course. They were going to risk it. The days were early. This wouldn't happen today. Don't take that as a career plan. But they said, oh, yeah, you can come in. You will have to do the entire Stanford undergraduate CS curriculum, but other than that, I was actually looking to do that, so this gave me ground cover to do what I wanted. And then finishing that, this was tail end of AI, joined as employee number 6, doing the first Windows-based electronic medical record. No disrespect to Microsoft, but Windows 2.1 was not really a great platform to write software in. It was a rare day that it wouldn't crash before the end of the demo. Now, you could argue that was our fault, but I think there was plenty of confusion all around. Then worked doing enterprise software, so computerized physician order entry and a lot of modern computing, a lot of modern imaging things with Siemens. Some stints at Ohio State on the academic side and premise health and provider side, and had been interested in a lot of policy things when I was at Siemens, doing a lot of that, so I was aware of the ONC position and threw my hat in the ring, and it turns out there's probably not a lot of Republicans interested in informatics, at least identifiably Republican. So, had a little bit of a hook to get considered for the position. And that's the background.
So what is ONC, and where does it fit in the federal structure?
So ONC is the Office of the National Coordinator of Health IT, and I'm the national coordinator. So clearly for health
Sounds like
IT.
an aspirational title.
It is. It was absolutely an aspirational agency without a budget. If you ask David Brailer in 2004 when it started, he did a heroic job, no budget, just a little bit of attaboy from George W. to, hey, we need to do something about EHRs. It obviously got a vast sum of money in high tech, in the Meaningful Use Program, which has a certain wide notoriety. If you talk with David Blumenthal, the goal there was as much to spend the high-tech dollars in economic stimulus as it was to have, a clean, crisp EHR strategy. So they did what they could with the spending pressures they had. We're a staff division within Health and Human Services. So the operating divisions are things like CMS, FDA, CDC, Indian Health Service. There are a number of smaller things. So we're one of the smaller ones. It's a staff division. Nominally, I report to Secretary Azar. As he points out, he has 45 direct reports. So, the actual management structure is a little bit of a consensus-driven activity in there. But we're charged. We get $60 million in tax dollars last couple of years, and we're basically charged in the past with encouraging electronic medical records. We do a lot of work in standards. So a lot of the FHIR standards you've seen, for example, the Apple Health Kit, came directly from things at ONC. My predecessors at ONC funded and supported. If you look today, under 21st Century Cures, which I'm sure we'll talk about, we've been asked by Congress, and I think this is the consensus of everybody in informatics, so it's not I wouldn't call it a special ask or an ask out of the extraordinary. It's really an ask of just do what everybody has a consensus on, which is make these EMRs more usable and less of a pain in the you-know-where, and get them to interoperate. I think people thought, well, don't computers interoperate? Well, no, they don't. Computers are just rocks, not even pet rocks. And I can see some people are laughing. That's an age-defining thing if you laugh at that joke, by the way. It's not allowed under HIPAA. We thought there would be interoperability somehow magically, but that takes work and standards. So that's what we're about today.
Well, so let's expand on that a little bit in terms of the mandate. Are we?
Yes.
Do you consider yourself sort of post-meaningful use and now a new array of mandates? And if so, what's the origin of those? How much of it comes from Congress via opinions or legislation or from interaction with the community? What is the mandate and what's the source of that mandate?
Yeah. I would say we're post-meaningful use. Now, there are a number of things that have sort of survived from that, but we have, as frankly to the prior administration, pulled back on a lot of the meaningful use things and tried to make it less challenging. Administrator Seema Verma under CMS has really cut back a lot. We're calling it promoting interoperability. The mandate is actually very explicit from Congress in 21st Century Cures Act. So there's the core things we do are explicitly required by Congress. So there's the 21st Century Cures Act passed in December of 2016. You may know it for its most part. Most of the act deals with making the evidence gathering process for the FDA more modern, right? So we have vast costs to the public in these controlled, double-blind clinical trials to provide the evidentiary basis for FDA decisions. It basically makes new molecular entities $3 billion things and takes a decade to do, roughly. And so everybody realizes, hey, we have a lot more information than we did, right? That mode of doing business is before we had data, right? And where we had to use a lot of statistics on a very narrow data set. The world of today is a lot of data that we can use crappy statistics on. So if you've heard of NoSQL databases, all that, I mean, that's sort of a polite way of saying we're going to do loosey-goosey, inconsistent data stuff, but it'll be great. For the right cause, it is. For the wrong cause, you use the wrong tool, bad things can happen as well. So the mandate, just to give you a sense of it, this was December 2016. The election had just happened, as you know. Probably everybody was surprised at the outcome. I shared yesterday with the Cambia folks down in Portland. When I walked in for an interview with Tom Price, I said to him, he's sitting at the big desk there, hiring his staff. I said, well, I never expected to see you here. And he said, me neither. So the election was a surprise. But Cures was really getting together, rare bipartisan. So Cures had 392 votes, I think, in the House and something like 92 votes in the Senate. So essentially unanimous. It was signed by President Obama, and I can absolutely assure you President Trump, the White House, Secretary Azar, Administrator Verma, obviously ONC, we are very much behind it. We've had very cordial interactions, a lot of work together with the prior administration. You have Anish Chopra, who is Chief Technology Officer under President Obama, speaking shortly. So Anish and I have worked together on a bunch of these things. We build on work that was done by in particular, Farzad Mostashari and Karen DeSalvo. So, it really is a bipartisan effort. I think there's a lot of support there. The White House, absolutely. We've had multiple meetings with Jared Kushner on this stuff. Jared is very interested in this, and I know he has gets a bad rap, but he's actually very charitable-minded, extremely smart, and extremely thoughtful about sort of modern approaches for the American public on stuff. So I would encourage you, if you have a chance to interact with him or listen to him, to actually, put preconceptions aside and think deeply about the comments.
So tell us a little bit more about what the themes that emerge from the 21st
Yeah.
century cures, how that translates into a mandate, and
Sure.
what your priorities are.
Yeah, so there are three specific big asks. There's some other asks, but there are three specific big asks in the 21st Century Cures Act Title IV that come down to ONC, or that deal with information technology. And we have a proposed rule out, healthit.gov. You can comment on it. The comment period is currently on. There's a sort of parallel rule with a somewhat different mandate at CMS. I'll briefly be able to touch on potentially, if you wish. But the law explicitly says there shall be no information blocking. So the law says the base assumption in America is patients control their data and can get their data. And no matter how much you've built up a delivery system that is based on capturing all referrals within your system, and no matter how much your EMR vendor would like to do blah, 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 monetize the data and charge the sky's the limit, the patient actually is in control of their data, and that data to the patient cannot be blocked. So that is illegal as we speak. And it is, that mandate falls on certified electronic health records, networks and exchanges, not heavily defined, so there's a lot of lawyer time spent on what that definition might be, and then on providers. That's the first provision, and that was the basis of a number of congressional hearings in the prior administration, so it actually has a bit of a history to it. So that is one thing, is we are charged at ONC in our rulemaking with defining allowable exceptions, right? So you can think of that as operationalizing it, right? Congress passes a law, and then there's a whole bunch of operational details, so then the agency, it is assigned to the agencies, usually almost invariably through the secretary of the relevant cabinet agency, who does what within that cabinet department. So information blocking, one. The next thing, Congress heard a lot of complaints about the various health information exchanges. They don't talk to each other. Providers are saying, I have to spend all this for an interface. I can't get my data. So what Congress said is, you, ONC, whoever, you guys just make these people talk to each other, and we're going to call it a trusted exchange framework, and there's going to be a common agreement, and they can then voluntarily talk to each other. So that, if you take trusted exchange framework common agreement, you have TEFCA. So that obviously is a funny kind of thing, because there's actually a fair amount of implicit specificity there technically. We've had, because there's a lot of implicit technical stuff, to really try to get that as well polished as we can. We've had one public comment period to get people on board there. We are in the very near future going to have a second public comment period on that, a 60-day comment period to talk about those things and get people's comments on it. The format will be, we will do a high-level directive, including things like getting payers involved in this exchange. The providers have frankly prohibited them in the past for a variety of problematic reasons from the paying public's point of view. Then we'll have a funding request for a nonprofit entity to manage this common agreement. You know, it's essentially a version of a standards organization, if you will. So that will be out for public comment soon. The third big and probably the most transformational thing is Congress heard from a lot of entrepreneurs, software developers, computer science folks, we can't get at this data. It is locked in the EMR, and nobody in the EMR land will give us this data. We'd like to do a brilliant new app. Pick your app, pick your application. We can't do it because some combination of the providers and the EMR vendors won't let them do it. Now, we actually, under Meaningful Use, had some stuff on open APIs, a request that actually is now coming in January. This other stuff has, when the rule is final, we'll have a 2-year period to come in the APIs. But what we did was, I think, honestly, a little bit too short, which is we said we used the phrasing open API, not to say this isn't secure, but open API just means you publish some spec, but it can be absolutely unique and vendor specific. That's not part of modern computing, right? These one-off things that basically further entrench, common, these current contenders, don't allow competition, and frankly, in some cases, are just simply archaic, right? I mean, you look at this from a software engineer point of view, and it's like, ooh. So what Congress said was very explicit, and Congress said the words that are used in cures are application programming interfaces without special effort. So yes, exactly. So that's a very specific, right? So that's about as specific a mandate as you can get, right, in a law. And so then it, but it does require what is without special effort. I think when you said in 2018, 2019, that we now know is extremely clear, right? Without special effort API is using the modern app economy smartphone API family that populates the smartphones that probably half of you are looking at right now as I ramble on. What does that mean? Well, what are those? Well, those are, the RESTful stack, right? So a fairly asynchronous, stateful, protocol on moving information. You'll see it in your browsers as gets and puts if you ever look on the browser line. With the JSON, JavaScript Object Notation, which is just a simple, very sort of flat file-ish data standard that you can read with Microsoft Word or Notepad or something, right? It's just a text thing. There's no special characters, no exotic stuff. You can also use it with the angle brackets and XML, but again, that's a little bit old school. Obviously, a lot of people do that. And then if you think about those two things, well, there's nothing in healthcare about that. That's just generic, right? That's what Google or Apple use to serve their map API, or that's what I believe the weather service does to serve their weather API. I'm sure the NFL or whoever else probably has these things. So on top of that, it turns out already in the works was a healthcare standard of JSON, of this JSON. It's referred to as JSON. It stands for JavaScript Object Notation. Sorry, called FHIR, Fast Healthcare Interoperability Resources, FHIR. And FHIR is just, you can think of it as, healthcare terms, healthcare vocabularies, healthcare allowed terms, and some healthcare specific formatting so that, to get the right granularity to get, a med or whatever out. It's a work in progress, but clearly having that API with OAuth 2 for security is application programming interfaces without special effort. Explicit mandate from Congress, and it is out for comment right now. So it was, frankly, as you ask, and I sense in the skepticism question, I was also, frankly, shocked that the mandate was that specific. I mean, I had ideas in coming in about interoperability and had thought a lot over the last decades about doing that. I mean, when I started in this business, interoperability was a serial port. Most of you don't even know what that is, but there was something. And then we went to the parallel port. And this is, it wasn't until Windows 95, I believe, that you had TCP/IP. Anyway, that's the mandate. It was quite explicit, and that obviously is helpful when you're doing things that can be transformational, but yeah, that a lot of people are potentially not interested in doing for their own reasons.
So is it fair to say Congress gave you a grenade with which you can blow the doors off the walled gardens? Is that really what's going on?
Yes.
Yeah.
So, and there's a little in-crowd joke about walled gardens, which I'm not going to go into more detail, but yes, some of that was quite explicit.
Okay, so is this just a notion that this has got to be good, or is this a component of a longer-term strategy or vision, or all of the above, or how does it fit to the longer-term?
So I think, and we talked about this a little bit before, in truth, I think there's two ways to look at what we do, and depending on the day and the time and my mood, I look at it in one of two ways. The simple mechanical way of looking at it is robust, elegant application programming interfaces have transformed our economy. And they've democratized all kinds of things that had been opaque and non-transparent before. And you can rattle off industry after industry, whether it is the music industry, the publishing industry, the newspaper industry, the taxi cab industry, probably a lot of companies here in Seattle. So industry after industry, the airline industry, have been utterly transformed into different price points and different service profiles through simply APIs, right? I mean, when we flew here and our flight was a little delayed this morning, you could look on the API if you wanted to. I mean, you could also look at the screen and sort of see, what's going on with your flight, right? So those are APIs, right? And that is everywhere. Decide, what am I going to wear today? I mean, I don't look out the window anymore. I don't have a thermometer. I just look at my iPhone, and it tells me what the weather is, and if it's wrong, I'm upset. Now, I realize the iPhone doesn't predict the weather. They're just doing an API from the National Weather Service, and just loading it with, the geolocation. So that's one big thing, which is that I think APIs are inherently transformative. Now, I think the reason Cambia Grove exists, the reason we're here, I think the reason that ONC exists, the reason we're having this discussion is because there's something deeply wrong with American healthcare. You didn't need to come here to hear that. That is not news, right? We all know that. It's the, political topic of the last several elections in ways large and small. It is our daily experience if we have to interact with the healthcare system or pay for somebody who has to interact for the healthcare system. And believe me, even if by some chance you're not in one of those two categories, you're certainly in the category who's paying for it. A vast amount of the real economic growth in the U.S. that's been provided by the IT revolution has been soaked up by the healthcare delivery system. So it is a major national policy. Now, when you think about that, and you think, so then you could ask yourself, well, how are you going to fix this? And the world, DC, is chock-a-block with solutions. I train as an internist, so if you're trained as an internist, almost by definition, you have some taste for diagnostic things. Now, I've practiced as an ER doc, which probably means you don't actually have a lot of taste for diagnostic stuff, and you just want to do shit. So you can factor that into questioning. But if you look at the diagnosis, right, of why we, the root problems in healthcare, which are not fully appreciated, amazingly enough, goes back to if you took Econ 1 in college, right? We know what efficiency is, what would be good prices and good value in the economy. That was defined in around 1850, 1860 by classical economists, and is when the marginal utility of the consumer, right, is equal to the marginal cost of the producer and is equal to a market price, right? The way we allocate scarce goods and resources in markets is through market prices. As you know, we do not have market prices in healthcare. We have this hodgepodge of goofiness. We do not have market prices except in a few things like LASIK and, you know, elective plastic surgery and, you know, herbal remedies. But in the mainstay of healthcare, we have no market prices. And so how do we get, you know, how do we get a market price in the economy, right? Because even if you think, hey, I hate economics, you know, it's the dismal science, don't forget a market price, you can think of in a totally non-economic term as a incarnation of all available information, right? Friedrich Hayek won the 1974 Nobel Prize in Economics for, you know, works he wrote in around 1940. The classic one is The Road to Serfdom, talking about how markets and information are key. If you look at the problem to be fixed in healthcare, how do you get markets and information back in? Then the original sins we talked about were in the 1940s that in wage and price controls in World War II, the health insurance became pre-tax, which meant the marginal tax rate in World War II for top payers, by the way, was 90%. So for those decision makers and companies, healthcare could be only 10% as effective in the non-market as in the market, and they had an incentive to purchase it. And that sort of all came along, and then in 1947, 48, you had the Hill-Burton Act that started the whole business of cross-subsidization, right? You come to an ER, all the hospitals in that era got subsidized bonds if they would, quote, treat everybody in the ER. So you had this tradition where people start thinking, oh, it's free, I'm not paying for it, somebody else is paying for it. Well, if somebody else is paying for it, we have to hide from them that somebody else is getting it for free, right? So the start of non-price transparency came with Hill-Burton. And then in 65 with Medicare, we started having administratively set prices. And then, as you alluded, Lee, we've had fix after fix after fix on that. I'm hopeful this is, I personally believe, this is the biggest pro-market move in American healthcare since the start of Medicare. Now, one could argue, as I sometimes argue when I'm held to account by, you know, for example, Eric Hargan as the Deputy Secretary, maybe that just says there have been no free market moves in American healthcare. And so this is a teeny weeny baby step. But it is that spirit of markets and the lack of market information. And it is now, we are generations of misallocation of resources. You know, what residencies, what hospitals. I mean, you go to most American hospitals, they're like the Temple of Dender, right? If I'm a patient who's about to be thrown into bankruptcy because of the healthcare bill and I'm uninsured, do you think I really want to be paying for that temple and all of those sheets and acres of marble? You know what? I probably don't. I'd rather not be in personal bankruptcy. You know, most arguably personal bankruptcy is from healthcare. There's one down the road, I'm told, in Mary Washington Hospital in Fredericksburg, Virginia, that has 20,000 people in the local courthouse in collections. The town of Fredericksburg has 28,000 people. Now, I'm sure it's the county, but there's a real impact to all of this stuff. Now, we have very elegant, polished people here, so only probably a handful of us really have had some family connection to this. But believe me, there are many, many people for whom this is life-destroying. And so we need to get this kind of market discipline back. So that's the animus of what we do.
Okay, so the idea is blowing the doors off and enabling patients to actually obtain and have command over their own data will accelerate market-like forces. So both the consumer, if you will, and the market are key here, and we're trying to enable both of those. Now, in some ways that's well-established economic thinking. In other ways, it's pretty novel in healthcare. So as you look at what you're trying to do and the long-term impact of it, and then you compare that to all your different constituencies from Congress on down to employers and to providers and payers and everybody else, who's with you? Who's petrified? How do you expect this to play out?
Oh, well, that's an interesting question. Well, actually, well, let me say a couple things here, right? I think there's obviously a big congressional interest. Congress hears many complaints about this. There's a lot of impetus to fix things. Congress, when you meet with a congressman or congresswoman about IT, the discussion doesn't start with, Fire or RESTful or JSON. It starts with, I wanted to get my MRI out of medical records and they wouldn't give it to me. Or they told me to go here and get my mother's chart and the clerk wouldn't give it to me because of HIPAA or something, right? That's what you actually hear, and that's what what the conversation is of constituents. So I think there's a lot of interest in Congress. Obviously, we have built a vast healthcare environment that will be under incredible pressures if there were a market economy. You could, if you were, a hedge fund manager or a venture capitalist or an entrepreneur, look at every activity in American healthcare as an arbitrage opportunity between what happens now and what would happen in an efficient market. Just to throw the range of it re-engineering, right? Most of our healthcare today is this year-over-year annual cycle. Even that is broken, right? Most other insurance we buy has longer-term things, whether it's multi-year discounts, safe driver discounts, right? Even the healthcare system is a very disempowering because, again, it's employer-based. So I think there's almost everything that is ripe for stuff. I bet there'll be a total transformation of things over time. So then, obviously, the providers will have existential issues here with that. Now, they're not going to say, we don't want to compete. They're not going to say, we don't want to information share. They'll have helpful thoughts like, we're worried about the patient's privacy, and we're worried that, the Russians will steal their data on an evil app. Right? That's what we hear, right? We'll hear, let's say, one EMR vendor is on the public record as, well, this will be like Cambridge Analytica, and we want to protect the patients. I will just throw out there, it has been I've noticed that the desire to protect the patient's privacy seems to be directly and inexorably connected to the value of lack of transparency in the business model of the people making the comment. Now you can, obviously we have a lot of issues with secondary use of data, but I think we have to think about that. So, but the beauty is this is federal rulemaking, so there is a notice of public rulemaking, and you are allowed to see every single comment that is submitted on this, and I am not allowed to act. An ONC is not allowed to act on any non-publicly submitted comments. So you will be able to have your answer as soon as the comment period closes, if you wish to read them.
I'm very interested in this enabling that you're engaged in as it relates to the more macro picture of American healthcare and all the forces driving change. There's a huge focus on cost. There's a focus on inadequate performance in American health system. There's been a focus and even a political focus on inequity, and then there's all these established markets. And as one of my colleagues told me long ago, he said, "Lee, never underestimate the power of the fact that the current healthcare system serves the economic interests of its participants quite well." And so if you look at the history of American healthcare, the power of economic self-interest has been very, very influential over time. But so now we look at all this. We know the system needs to change. But how is this enabling? What you're setting out to do is unlock the power of the consumer and thereby more fully activate a market-based approach to healthcare. How does that intersect with the pressure on cost, the concerns about equity, the what I would call the fundamental misdesign of the American health insurance business, where we insure everybody, except if you're elderly or sick, then we're going to put that on the government, right? So we've screwed up almost every component of this system. And is there anybody thinking about what you're doing in terms of its intersection with these other forces driving change?
Yeah, I mean, we've spent a lot of time in the administration sorting out what we can do here, right? I mean, as you know, we're in a sort of a challenging thing because without congressional consent, right, what we can do in the executive branch is limited. I'm very lucky in terms of stuff ONC does because Cures has a very explicit thing, but as you know, that was also the last bipartisan healthcare, and maybe arguably the last bipartisan anything that happened. All right, I mean, there's still hundreds of political appointees who haven't been confirmed yet, and we're over 2 years into the administration. So, unless there is a meeting of the minds, and you guys read the press just as much as I, and I think within the Democratic Party, certainly there are some fairly hard to reconcile elements there, and between Medicare for all, if you will, single payer, and sort of more eclectic things, and then there's a lot of back and forth on the details between the arguably more I don't want to use the term conservative Democrats, but the people who are willing to have multiple participants in healthcare, and various GOP members. There is some consensus on things like price transparency. There'll probably be a rule on some of the surprise billing things. So are there some areas where I think there's broad political consensus? To your overall question, yes, everybody feathers their own nest, and I have been reading about the history of guilds in the Middle Ages. There were 400 guilds, I think, in Paris, if you look in Wikipedia, in 1400. The Armorers Guild, the Helmet Guild, the Escutcheon Guild, the Harness Guild, the Harness Polishers Guild. Is that like, the Critical Care Medicine Subfellowship, right? The Sleep Medicine Guild, right? I mean, if you leave doctors to their own devices, it's like what Adam Smith said in 1776. You leave two businessmen and they'll, start dealing with the restraint of trade. I'm butchering his quote, sadly, but you've heard it. I think there are a couple sort of trophic forces, though, that are changing this. One, more and more, when it was entirely, let Blue Cross, Blue Shield take care of it, that world, the private sector, it's okay, it's not my problem, Medicare and Medicaid, whatever. Now with, at least in the private employer world, all private employers are pretty much, with the rarest exceptions, even trade union type of situations, are putting more and more of the costs on their employees. And so every year those costs are going up materially. You can look at your own bill. I'd be stunned if you're here and you haven't seen that. So increasingly, we're putting a market in through the back door, not through the front door, but through the back door, right? At some point, if the deductible's so high, so we think, and I know Cambia has invested in a number of tools here to, things like MD Save, to actually facilitate some of this within the self-pay part of the thing. But the self-pay numbers are getting large. They're $5,000, $10,000, right? Those are massive self-pay numbers. So I think we're getting some of this in through that back door of employers just. The other thing that we're doing that is part of this that may be transformational for the payers, right? So we buy healthcare, skipping the government for a second, but in the private sector in America, we either buy healthcare on our own account, right, the deductible part of things, the copay, or we have third-party payers, right, the insurers who do that. We've heard from a number of the big insurers that they can't actually get the data to shop either, right, that they're charged $5 per electronic download of a chart to get the data, and then the provider somehow, well, we'd really like to provide it to you, but we really can't. How on earth are we going to do any calculation around value if we have no information, obviously, on the price or the product, right? I mean, riddle me. So we're doing a number of technical things to facilitate that. So in this proposed rule, working with the HL7 standards group and the fire subtask force, in the Fire 4 release, we're going to have Cambia, to their credit, a number of the other payers are working with some of the big EMR vendors. We are going to have population level APIs to allow queries. So the people who are in charge under HIPAA of analyzing who should be in network or not in our care will actually have data. So they won't just have to do it because that hospital bought every other hospital and said, here, take it or leave it. They're going to be able to hopefully negotiate on, hey, wait a minute, your care is not good. We hope to extend that to relieve some physician burden with quality measures and other things. So I think when you look at the information that the public is increasingly forced to digest, doesn't have great tools today, I think they're going to be very receptive. When you look at the payers who have, honestly been a little bit of a satisficing relationship because ultimately payers are sort of cost-plus operations. So with a few exceptions, and I think Cambia, I believe, is one of them, most payers, yeah, we'll do a little cost control, but ultimately, since we're paid on the gross, we don't, it doesn't really, yeah, we'll take care of it for you. Don't worry, you go back, you take care of your things. Yeah, well, not to worry. So, there's been a little bit of an unholy alliance here on that. As both of those things get uncoupled, I think it'll be different. But that having been said, it's still a very sticky system. The administration is looking at things like certificate of need. There's a lot of stickiness everywhere. That
So I'm
gets at
interested,
your
now,
description.
So you open the flow of data and you give me a set of apps that I can use and charge me to have a more proactive role in my own medical care decision making. So I need the data, I need the app. But I also need an insurance plan that allows me to make my own decisions. And I need some kind of pricing guidance. And so is this going to break loose first in areas where bundles are being developed? I can imagine that as being a case where I could actually shop when I need a knee and I get a bundled price for a knee.
It's already happening today.
Is that right?
It is already happening today. So you see in a number of fronts, and we talked about MD Save, which actually does that. It's a company that for about 250, 260 delivery systems will quote single stop prices, right, for everything, all in. So the providers take the economic risk of the service. There's some add-ons for certain things, but basically it is a defined price, and the providers, believe it or not, are willing to do it at not very much above Medicare, because what this company's business model is to actually pay within 3 days direct to the provider's bank account. They've negotiated or helped the various parties negotiate each party's share of the pie. There are a number of price transparency things that are getting more sophisticated. Amino, Castlight had a big buzz a couple years ago. Healthcare Blue Book. There are a bunch of them out there that are doing that. So that activity is sort of, it's early, it's all around, but it's definitely out there. It's definitely out there. And then a number of the employers are figuring out ways to facilitate that. Some of them are relatively publicized, the Walmart, they'll pay you to fly you to where they have a negotiated price. I think you're going to see a lot more of that. So I think it's actually happening.
So let's talk a little bit, before we turn to the audience, about the implications of this general direction for other entrepreneurial efforts. We sometimes fantasize about CPT codes becoming a quaint artifact of history, and not selling our innovation because it fits to a billing code, but selling our innovation for some other reason. Do you think we're on the threshold of that? You sound like you're optimistic about the movement way here.
I wouldn't say I'm optimistic about the immediate demise of CPT codes. Folks should understand half the revenue of the AMA is from CPT licensing fees. So just as you talk about who's going to lobby, I assure you they're on the Hill constantly. And so it is one of the challenges in American healthcare that if you can't have a CPT code, it's very hard to get paid for stuff. But I think some of these business models are de facto ways of getting around that. I jokingly sometimes say, you may remember or have read, Descartes had the famous phrase, cogito ergo sum, I think therefore I am, sort of a tribute to humanity. It's sometimes like CPTO ergo sum. So I do CPT codes, therefore I bill, or some such. You can take that. But I think some of these forces actually redefine the product. So I think some of that brittleness and gaminess and guild, right? CPT is a big guild maintenance activity, right? Because the guild in charge of the potential competitive innovation has to approve the CPT code. So I'll just leave you with that little factoid.
So there are new tools for change and yet well-established obstacles for change. So in your last comment, what advice would you have for a room full of entrepreneurs? How do they think about where this is going and the potential for them to have an impact?
Yeah, obviously we're encouraging. Obviously we're optimistic about it. I think it's not going to be just, here's your version of the EHR, right? Somewhat cleaned up, somewhat made more intelligible at some level in some way. And some of that's happening already, right? I mean, Apple HealthKit is out there. There's smaller companies, PatientLink, Humetrics, Coral Health, who are doing that. I think the win will be, besides just creative things that I'm not smart enough to think about, which is where the real wins will be. And I know there's smarter people than me out, so I've always seen them. I've never been one of them, but I know they're out there, so I have an innate confidence of that as an existence matter. I think a lot of the wins will come in combining different flows of information, a la Uber or Lyft that combines, mapping, credit card, payroll, traffic services. I think obviously a lot of the illnesses, right now the 200,000 health apps basically don't connect to the handful of apps that have access to the actual medicalized data. With this, I think that world is going to change. I think a lot of those folks will think, oh, now that I have their data, now that I know what the meds are, if I can convince the patient to let me use that data. I think you'll probably start with a lot of disease apps, right? People will say, whatever your disease is, that data will have information. So I think that's where this is going to start. There are a lot of disease communities, and I'd be a little bit surprised because that's, I think, the lowest hanging fruit.
Yep. Okay. Very good setup for you all. Who has the microphone? Yeah, okay. Let me ask you to please wait until you get the microphone because we're recording this. So who has a question?
Thank you for your terrific comments. My picture of this landscape, although I love the idea of the hand grenade to the door to blow it up, it strikes me as more of a post-Game of Thrones landscape. The White Walkers control the APIs or the EMRs, however you want to kind of frame that. And what kind of forces are going to be required to counter that? As Lee said, economic self-interest is a apt description of what's evolved and why. And it's not in the major EMR companies' interest to open up the data. It's just not. It's not in their economic interest unless they're playing a future technology game. I don't see any evidence that they are. How do we bring this into reality? I mean, how do you get past that deep fundamental challenge?
Well, I think there's two ways to look at it. So first of all, a lot of cracks in established things start small, right? I mean, some of this is the boulder and a small crack in ice. And every winter, a little bit more water gets in, a little bit more water expands when it freezes, and the crack in the boulder, and pretty soon the big rock is lots of little rocks. So I think there's some of that. Now, when I mention that to my colleagues in the agency, they roll their eyes. But of course, that takes time. Congress, helpfully, actually provided a massive incentive because they know, as you both pointed out, that the built environment doesn't provide many incentives. And they said the federal role as a payer is we're going to force this, right? So Medicare spends over $1 trillion, CMS, so Medicare, Medicaid spends over $1 trillion a year, a bit over a third of the entire American healthcare spend, roughly. And that alone basically says you will have these APIs, you will enforce them, and we're going to have a series of incentives for you to do so and disincentives not. And in some cases, you won't be allowed to participate in Medicare if you don't. So the Medicare rule, which we didn't talk about, parallel rule, same time cycle, same comment period, basically requires payers to put out claims data. Again, part of this drip of discovery and transparency. It requires the payers to share the data. It requires things like electronic provider directories to make computation about this better. It also is a condition of participation. Again, proposed rules. You can say this is the most horrible thing in the world and Western civilization will end in your comment, but to actually further require hospitals to share data downstream with nursing homes and all of that. So some of these data flows are for all intents and purposes mandated. The Cures Act for EMR vendors, network exchanges, there are what are called civil and monetary penalties, up to $1 million per event. An event in IT can be defined as granularly as you want, depending on the enforcement discretion, right? Is it a bit? Is it a byte? Is it a word? Right? I mean, it won't be defined that narrow, not to worry, but there's certainly a lot of risk. If that's the game you're playing, you gotta, if that's your game, you have enterprise risk on that. So I think there are some very powerful forces that Congress put in because they made the same observation the two of you did. I mean, don't forget, if you're sitting as a member of Congress, these interests are going through your office every day, every 20 minutes, all day. Every day you're in session, and frankly, the days you're not in session, right? We don't, except for Maura and some people who have lived in this world, it is nonstop. They hear all of these things, and it's pretty clear what's going on. I mean, there are some groups of lobbyists who've actually been so ineffective, I believe, they've actually brought harm on themselves. I can think of at least one medical specialty that, I'm not going to name it, but almost everything bad that has happened to them has, when you read the tea leaves, been almost entirely and purely of their creation through their lobbying skill or lack thereof. So it's a busy, noisy environment.
Just on that note, Don, I'm curious whether the members of Congress hear the other side of the equation, which in my understanding is that the substantial, excessive explosion of healthcare costs has dramatically, economically limited society's ability to do other things. And the most obvious crucible for that is state legislatures, where they've had to deal with the inflation of
and all payer claims databases.
And education has been shorted because of that. Now, it's maybe less obvious at the national level, but there's a counterpoint to. I mean, most people think that we spend close to $1 trillion a year in healthcare that we really don't need to spend, and that would make a big difference.
Yeah, but the problem is, so first of all, I think Congress absolutely realizes that. I think with a handful of exceptions, people in Congress who, I'm not going to characterize, but I think basically most members of Congress realize it pretty clearly. Again, as you mentioned earlier, the question is what to do about it. So people understand that this is draining the productivity of the United States. What was the other point?
I'm just curious whether they realize, as a pushback against the self-interest lobbying,
Yeah.
whether they realize that the counterpoint is that society's ability and
Yeah.
their ability to do important things is.
Yeah, no, I think that part is absolutely realized. I think that part is absolutely realized. I think again, it becomes an issue of what your sense of the diagnosis is, what the causes are, what to do about it. Your comment earlier, I wanted to mention, is the $1 trillion that is, quote, unnecessary. And healthcare economists have actually looked at this in a fair amount of detail. I think the real issue, and so I've been practicing medicine for 30 years and like to think I'm a pretty decent clinician, have a pretty real sense of what actually adds value for patients and what's just, marginal or what's just basically goofy. And, I've seen pieces of that. I think the real issue is actually mispricing of all of the services, so they're all misallocated. It's not that any one thing it is rarely that something is, it's relatively rare, let me say, that something is inappropriate in the construct of American medicine today. I know there's the choosing wisely and a bunch of folks who seem to believe that's not the case. Most of the choosing wisely specialties have wisely chosen to pick somebody else's specialty as the thing that's unnecessary, not their own specialty. I would just throw that out there, with maybe the exception of the gastroenterologist on odd-numbered days. You can reflect on that. The real issue is the gross misallocation of resources globally, right? That is things like, why do we spend, for example, house staff training? So when I started as a med student in whenever that was, 1977, you could get out of, you could be in practice as, let's say, a cardiologist 4 years after the graduate of med school, right? You could short track residency, and the fellowships were 2 years. And so now it's impossible to get out in less than 6, and frankly, often more, right? Because you need like a sub-fellowship on top of the fellowship. It's not enough to have cardiology, right? You have to do the year of research. What on earth are we requiring every specialist to do a year of research? This is just, guild stuff we can get away with, and, and sort of the misallocation in academia. And then you have, a sub-fellowship, and then all these procedures are dueling in ways that are economically inefficient. So every resource, everything is misallocated. My favorite quick example of an alternative way of thinking about things that I love to mention, again, is looking at heart disease. So we have a vast cardiology establishment, as people know. You could prevent half of all heart attacks in America by either simply putting everybody on generic Lipitor, of a certain age and certain risk factor. And if you didn't want to do that, because, it is after a medicine, we don't know what the side effects are. If you had a true market economy and allocation, you could do a cardiac CT angiogram, put it on the truck, move it around to whatever site, and do that for easily under $100 a pop. 10 years before the heart attack, at the first sign of plaque, right? We instead do acute care. You have a heart attack or you have chest pain, which means things have progressed. And we do things in a very, globally inefficient way. If we had a market, there'd be somebody providing that service and doing it. We have a guild that, fights on who could even do it. And then we have our payers who say, oh, well, that's not fully evidence-based. Now, 5 years later, it's evidence-based. But, I mean, even 5 years ago, I mean, I remember it was incredibly hard to lobby. Even Medicare was paying for this. Medicare could do a cardiac CT angiogram at a market price on every single one of their beneficiaries every 2 months, and save money on the $100 billion they spend on inpatient heart care, right? I mean, we're just nuts about this, but even getting the Medicare people to think about that, and we eventually got it covered through political lobbying, to say. But you know, that type of gross inefficiency, if you had market allocation of resources, entrepreneurs, folks here would say, hey, wait a minute, why are we doing this? And nobody wants a heart attack, nobody wants heart failure, nobody wants any of this stuff. And they would say, hey, you know what? I like this. If you're an employer, if you're the University of Washington and you're on the hook for this, you'd say, hey, we're going to offer this as a benefit. And you know, soon enough, you'll be able to monetize that. You know, you don't need a heavy discount rate to monetize that. So I think it is really the price and the misallocation of resources gets back to the comment we made at the very beginning about microeconomics and the efficient frontier. That's where the waste is. It is not on we didn't have enough decision support on when to order some high-priced test. Everybody seems to think, well, if I just had more decision support or more prior auth, you know, this would go away. Easily $1 trillion is wasted. You could probably argue $2 trillion is wasted, but it's not wasted in the way I think that is commonly implied.
Good point. That sounds like entrepreneurial opportunity here. What's the next question?
To what extent do you see this movement having an interplay with HIPAA? Some of the constituents that you have mentioned have said, you know, there's a risk of, you know, patient privacy issues with this. Is there anything real there? And if so, do we expect to see any changes around HIPAA as it relates to this?
Okay, interesting question. So there are two parts there, you know, what's real and what's not, right? So it is often said, well, you know, these apps are not secure, it's a security risk and stuff. The security of the transmission is perfectly fine. That's OAuth 2. It's used by every bank. It's used by every brokerage. That part is perfectly fine. What is conflated is security with the question of secondary uses of data, right? So the issue, it's sort of all put into a jumble to obfuscate, but the real issue is I as a patient, and we will get to the HIPAA, I as a patient have exercising my HIPAA right of access, point at the provider's URL, download my data on my smartphone. At that point, under the HIPAA right of access, it is my data and my responsibility, right? So then I have an obligation to figure out, is this app going to do it? Is it trustworthy? Right? What might they do explicitly? What's my risk of them doing something sneaky, right? And I think there are a couple things to say about secondary uses of data. First of all, obviously it's a national debate, right? The European GDPR regulations, the California regs on this. I think Washington State is trying to do stuff here. So there's a whole bunch of states trying to rush in and do various things. You know, whether Congress will preempt these states, seems to me they should. Seems to me this is exactly, it'd be hard to imagine more interstate commerce than this type of stuff. I mean, how could this not be interstate commerce? But, you know, again, there's lots of people who are going to sort this out. So, you know, and then there's a little bit about what is the consent mechanism. We could talk about that. And is what is told to the patient honest or not? That's enforced by the FTC. They're starting to look at that, but again, that is, you know, fixing to look at it is not the same as doing anything about it, but they're starting. And then there's the implicit question, are we as a public, are we smart enough to be in charge of our own data, or should the man or woman, you know, take care of it for us, right? I have folks, you know, major EMR vendors, we'll take care of it. You know, the public, they're not that smart. We'll take care of it for them. You know, they can't trust it, right? That sort of paternalism in American healthcare. Our belief, I think Congress's belief, certainly this administration's belief, is Americans can actually choose stuff. They can learn that they have to be careful about where they download their data. We can have all kinds of accountability on this with tools we have in our legal system, and people will, in fact, be smart. Every day, we make decisions that affect our life with things that are potentially dangerous, and somehow we mostly survive. Every day we decide, are we going to drive? You know, every day I use an example, like just the power of branding. People who love regulation forget markets control quality by branding, right? You pay more for the brands you trust, right? That's how markets handle quality. Let's not forget that in the discussion about privacy. And again, markets do it. Who here can remember the last time they bought an off-brand piece of manufactured food that didn't have either a national brand or a house, grocery store brand, right? We don't buy stuff in boxes from people we don't know because we want some quality, like what's in there kind of thing. So markets can enforce that. I think we'll do it. Under HIPAA, that information is the right of the patient under the HIPAA right of access. The providers are required to provide it, and then once they provide it, it is not their liability of what happens to it downstream. Now they're allowed to have a big dire warning, when you download your data, this data, whatever, right? And they should. We've talked with one vendor who told me she wasn't going to do that, because she didn't believe that patients should have this, but you can sort out that'll be determined by the providers. So there's nothing, and again, American healthcare is very paternalistic. I have many of my colleagues who frankly say, oh, the patients can't be trusted, and I tell them all bullshit. But then they say, well, you're a moron anyway, so thanks, good to see you, let me go away. Right, so that's a national discussion. Honestly, we'll sort that out. I think the providers will do what the public and the EMR vendors will do as they're asked. They've actually, the big EMR vendors have actually done a number of things to support the API technology. So, Epic, Cerner, pretty much all the big vendors, Allscripts have FHIR interfaces running today. So I think, they're providing the technical framework. They're sitting on the standards committees. So I think, they notionally are ready to do it, but it's up to the providers to do it. You will see some guidance in the very near future on making it explicitly clear through FAQs on what the HIPAA right of access is, if I don't miss my guess.
We can take one final question. Hand up here.
So I know a lot of the 21st Century Cures Act was about the Precision Medicine Initiative. There's a lot of talk about data and providers and information blocking, but most genomic information right now is coming through into the EHR as a PDF rather than as discrete data. So because that's so much part of the initiative and that data is available discretely, is there any part of the discussion around making sure that the lab data and the genomic data is actually available in a manner that can be acted upon as well?
Yeah. There are a number of initiatives. So ONC works with NIH. I mean, obviously NIH is the controlling influence since they're paying for, most of the raw science that's generating this. So we have, Sync for Genes and Sync for Science as specific programs. Teresa Zayas-Caban, who's our Chief Scientific Officer, is working with NIH to, work with them to support, this app economy and stuff. The actual, what comes off a sequencer, if you will, that is really, I think, for the basic scientists to decide, what that formatting is. I mean, that is really, deep in device technology. On the more general clinical things, we have as part of our proposed rule, the U.S. Core Data for Interoperability that gets at the early data that we want to standardize. It is not DNA sequencing. It is, meds, allergies. Now, some of this we've already had. The add-ons it used to be called the Common Clinical Data Set. We changed a little bit. The add-ons on this go around are open notes, so text notes that you could put NLP to, again, entrepreneurial opportunity, and some provenance. So, computers can do some reasoning about where it is. it's worth calling out. We don't think the technology is there to do any kind of mandates, either around genetic data or something that's maybe a little bit or a lot more broadly used, which is imaging data. Not the imaging report, but the actual image. Those all are heavily standardized through DICOM, but the problem is the payloads are so large that we can't, we can't do rulemaking to, have 500 megabyte MRI images, going to your smartphone. You won't have room for photos anymore. We'd shut down Instagram. We don't want to do that.
I don't want to do that.
Right, yeah, so
But,
there are broader public policy considerations here.
But this is a good indication, I think, that the fan out, if you will, or the implication of moving to open APIs like this, there are all kinds of potential implications, which is exactly your intent. You can't foresee them all, but the potential for change and for patient-centric innovation is very large due to this enabling. So it's good news for all of you. We desperately need to innovate in this space. The biggest industry in the United States, and so far the least impacted by the digital revolution.
Yep.
So, so thank you all for coming and for your questions. Let me invite you to stay and enjoy Cambia Grove's hospitality and to pester our speaker with still more questions. But first, help me thank him.
Well, thank you very much. Thank you. Thanks.
Thank you.
Great, thank you very much. Thanks.